All right, let's go ahead and get started. Good morning. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and I'm delighted to welcome you to Grand Rounds. Sorry I can't join you by video. I'm afraid I'm having some technical problems, as is Lee Sanders, who's going to be introducing our speaker, who scrambled and went to another building. Seems to be some Zoom challenges, but I'm happy to see many of you joining us this morning, and we'll go ahead. So I just have a few messages. The first is, as always, make a note of the text code on this slide here for CME. And then, of course, you can see today's speaker is Dr. Koltai. Want to make sure everyone remembers that next week we're not having Grand Rounds because it's the day of the Pediatric Academic Society meeting where we have a huge presence. Please, I hope many of you are able to attend PAS and see all the different Stanford speakers. And then our annual event of all things the following week is the Red Book Vaccine Update, something that Bonnie does for us annually in her capacity chairing the Red Book. All right, next slide, please. And we just want to call your attention to the monthly department meeting next week. Will very much be focused on the wellness work within the department, both 3 different champion reports of some really successful work within some of our different divisions, as well as myself and the associate chairs addressing many of the comments and the things that came out of the wellness survey. So we look forward to sharing that information with you and talking about some of the next steps. So with that, I'm going to pass things off to Lee Sanders, our Chief of the Division of General Academic Pediatrics, to introduce today's speaker. Welcome, Lee. Thank you.
Thank you, Mary. And it is my great privilege and honor to introduce our Grand Round speaker today, who is Dr. Peter Koltai. Peter is Professor Emeritus of Otolaryngology and Pediatrics and has been a member of the Stanford University School of Medicine since 2004. Peter was born in Hungary and educated in New York City. He completed his ENT residency at the University of Texas and did a fellowship in pediatric ENT at London's Great Ormond Street Hospital for Sick Children. Before arriving here at Stanford, he was professor of surgery and pediatrics at Albany Medical College and then head of the section of pediatric otolaryngology at the Cleveland Clinic. He has served as division chief of pediatric otolaryngology here at Stanford from 2004 to 2014. And he also served and ably led the medical staff office as president of the medical staff of Lucile Packard Children's Hospital from 2012 to 2014. He has held a number of national leadership positions, including past president of the American Society of Pediatric Otolaryngology. As with so many of our peers here, he's the author not only of over 100 publications in peer-reviewed journals, but he's also the author of several books and many chapters that have focused primarily on creative solutions to difficult surgical problems. One thing that's unique about Peter, however, is that he is an artist. He is an artist not only in the operating room, but also on the page. He has illustrated some of the illustrations that come with many of his book chapters and publications. And he is an accomplished painter and sculptor in his own right. And I have had the great opportunity to see his work here on campus. He is also an advocate. He has devoted himself nationally to advocating against for the prevention of battery injury, button battery ingestion by young children. And he has worked internationally in global health. He's a fellow at the Stanford Center for Innovation in Global Health and has been working with colleagues at the University of Zimbabwe, establishing a pediatric ENT service there at Harare Children's Hospital. So he's an artist, an athlete, and I'm happy to say also a colleague and friend. And Peter, please share with us some of your teachings today. We're looking forward to that.
Good morning. Thank you, Lee, so much for that kind introduction. I wish my mom had been on our Zoom meeting. Anyway, it's an honor and a great pleasure to present Pediatric Grand Rounds once again this morning. I began medical school in 1971, 50 years ago this year. I've been privileged with an amazing career, although never in my wildest dreams could have foreseen my final year in medicine to be so utterly strange, enveloped in this nightmare of the pandemic. Over the years, I've observed many changes in our ancient craft, much for the better. And one of the most interesting and beneficial changes has been the development of evidence-based medicine. Unfortunately, it is my perception that this has coincided with the devaluation of experience, a devaluation of the artistic component of our medical culture. However, I propose to you that evidence versus experience is a false dichotomy. Experience is the source from which evidence is drawn, but then evidence informs experience, adapting it, which then generates new evidence, and so the cycle turns. This will be my theme, my synthesis for this presentation. I have nothing to disclose. We have nearly 150 years, 10 generations of literature in my field of otolaryngology, a wealth of important observations and experience. This body of knowledge is the evolved canon of our field, which all of us were trained in, our cultural heritage. Yet much of this information was developed with analytical tools, which rarely stand up to the rigors of modern study design. Starting in the mid-1990s with the work of Professor Archibald Cochrane at Oxford, the emergence of evidence-based medicine provided tools for better analysis of unrelated data to limit bias and increase the power of the observations. While there's great demand for evidence-based medicine, what is interesting to me is how hard such evidence has been to come by. The challenges we wrestle with daily are the tasks for which there are often little or contradictory evidence to guide us. There always seems to be clinical puzzles which require a custom solution for which intuition and expertise are the key ingredients. We often practice in a haze of ambiguity. What maintains our ability to function and stay balanced is our experience enhanced by the collective wisdom of our culture, which when you think about it, is really the evidence that's available. Given that ours is now the age of evidence-based medicine, giving this final presentation here at Stanford, highlighting the importance of experience, I was afraid this might be a grand opportunity to fall flat on my face. Nevertheless, after 45 years in otolaryngology, learning, caring for the sick, operating, and teaching, and having tasted the sweet thrill of success and the bitterness of failure, I believe I have some insights to share with you about both evidence and experience. The trajectory of our lives, our stories, shape our view of both evidence and experience. It is an emotional, intellectual, and aesthetic journey, and in each of us, it leads to a specific and personal perspective. I'd like to briefly tell you my story. I always wanted to be a doctor from as far back as I can remember. Around the age of 10, I realized I could draw and build things. My first thought when I saw a new thing was, how do I make one? I learned early on that if I could draw it, I would know it. My visual learning style helped me succeed all through school. Right from my earliest days at the Albany Medical College, I knew I wanted to be a surgeon. During my third year surgical rotation, one of the first cases I saw was a radical neck dissection by the chief of otolaryngology, Dr. Jerry Goldstein. To me, this was jewelry. My path was set. I was lucky enough to be accepted for my ENT residency by Dr. Byron Bailey at the University of Texas. He was another amazing mentor. We had large surgical experience and were also encouraged in academic pursuits of research, presenting, and publishing. The experience of surgery was wonderful. The learning of skill, the growth of confidence, the problem solving, the freedom to improvise, and most especially, the sense of heightened awareness, the elasticity of time and the intensity of focus. I had never felt so alive. As a young academician, topics for research, publication, and art were all found in the operating room. Experience was also a source of innovation and creativity. During the second year of residency, we rotated once a week at the hospital of the maximum security prison of the Texas Department of Corrections in Huntsville, Texas, where we ran a clinic in the morning and an operating room in the afternoon. It was where we were supposed to learn rhinoplasty, nose jobs. Huntsville was famous for its Texas prison rodeo, where inmates routinely got injured. Nasal fractures and deformities were particularly common. The only problem was that we never had any attending coverage, so we ended up having to figure out how to fix these catastrophes on our own. My anesthetist was an inmate. My first assistant was an inmate, as was the circulator who turned the page of the surgical atlas on the Mayo stand at the head of the table as I made my way through the early cases. My inmate assistants tried to teach me, but I soon recognized my incompetence utilizing intranasal techniques. So I learned the external rhinoplasty approach to rhinoplasty by necessity. Eventually, I had a long backlog of nose jobs in my clinics. I'm not sure if it was due to my results or liberal use of postoperative pain medications, but I finished residency confident with this technique. Soon after residency, I returned to the Albany Medical College and rejoined Dr. Goldstein as a general laryngologist with interest in head and neck surgery and facial plastics. In Albany, we worked with neurosurgery, performing hypophysectomy. The prison experience provided the impetus for using the external rhinoplasty approach for this procedure, as opposed to the classic sublabial technique that had been used since the time of Harvey Cushing. We then applied the external approach for nasal problems such as rhinophyma, septal perforation repair, and nasal valve surgery. Sometime in the mid-1980s, I found my true calling, took a year of sabbatical and moved my big family with 3 kids and a wife to London for a pediatric otolaryngology fellowship at Great Ormond Street Hospital for Sick Children with Mr. John Evans and Mr. Martin Bailey. With a new focus on children, my experience with external rhinoplasty in adults provided a reliable technique that was applicable to pediatric problems such as nasal dermoids, cleft lip nasal deformity, and even unilateral choanal atresia. And finally, I found the external rhinoplasty approach particularly excellent technique for managing nasal tip hemangiomas. Experience is liberating. It's a source of creativity and it's a source of courage. And ultimately, it's the foundation of surgical judgment. But experience can be a cruel teacher. This was a case of a 1-year-old infant failing to thrive because of bilateral vocal cord paralysis. I performed the tracheotomy as my first case in the morning and put the child in the intensive care unit. Late in the evening, the tracheotomy tube dislodged. An attempt to replace the trach tube resulted in the tube going into the mediastinum. The child developed bilateral pneumothorax, coded, and was eventually resuscitated, but suffered severe neurologic injury. The experience of this tragedy started me thinking about how to create a fresh tracheotomy tract that was safe for easy recannulation. The standard technique at the time was to use bilateral retention sutures as in figure A, which is the technique that we had used, and it had failed. Other techniques were available for adults, including cutting a circular window into the trachea, as in figure B, creating an inferiorly or superiorly based tracheal wall flap sewn to the skin, as in figures C and D, but all had limitations and drawbacks for children. What I realized was needed was a continuous mucocutaneous suture line, and the image that came to my mind was the classic children's fortune teller origami, which between the skin and the trachea would form a three-dimensional Z-plasty. This was the origin of our starplasty. Starplasty begins with making an X-shaped incision on the skin, creating 4 small triangular skin flaps. After dissecting down to the trachea, a plus-shaped incision is made into the trachea, creating 4 tracheal flaps. Because of the differential geometry of the skin and tracheal incisions, the flaps created are offset by 45 degrees, allowing the tips of each of the skin and tracheal flaps to be sewn into the troughs between the flaps, resulting in a continuous circumferential suture line. Between 1990 and 2018, we performed over 250 starplasty tracheotomies without a single case of pneumothorax or tracheal stenosis. The children had more rapid healing and less problems with granulation tissue around the trach site. Like with any pediatric tracheotomy, we had several accidental decannulations, but these were readily replaced without incident. What we did find that these required surgical closure when the child was ready to have the trach out. It has been said that chance favors the prepared mind. Experience is often necessary to recognize a unique opportunity for technical refinement. Curettes had been used to perform adenoidectomy since the 1880s. This was a technique I learned as a resident and what I was using until 1994. However, the limitations of curette adenoidectomy were recognized early on. I quote from the 1898 article by F.B. Eaton in the Laryngoscope, quote, "Dependence on the curette appears to be irrational. An instrument which scrapes rather than cuts will not remove it. As with many surgeons, ignorance is bliss, for after a hasty operation during which hemorrhage encourages them to believe they have been thorough, discover later that at the choana, a mass yet blocks the way," unquote. In 1994, a sales representative from Limbitech, a company manufacturing orthopedics products, showed me a bendable arthroscopy blade, otherwise known as a microdebrider, and suggested it might be useful for endoscopic sinus surgery in children. It occurred to me that the microdebrider blade had the same geometry as the suction cautery I was using for hemostasis after adenoidectomy, and looked to be the ideal alternative to the curette for this procedure. We found that the curved blade fit nicely into the nasopharynx and provided a precise and thorough adenoid removal. This was the end of adenoidectomy by Braille, since the precision of the procedure required full visualization of the process. We called the new technique powered adenoidectomy, and our early experience accumulated into strong evidence to the efficacy and benefit of the new technique, which is now used worldwide. The only drawback we found really was just the cost of the blade. After the experience with powered adenoidectomy and seeing how well it removed lymphoid tissue, my attention turned to the possibility of using the microdebrider for a minimally invasive tonsillectomy. For 20 years, I had lived with the postoperative challenge for children of the pain and the potential of bleeding during recovery. By using the microdebrider to resect 90% of the tonsil, leaving the tonsillar capsule intact as a biologic dressing, protecting the pharyngeal musculature, and thus avoiding the large tonsillar feeder vessels, we found that the recovery from surgery was half as long and significantly less painful, and almost totally eliminated the threat of postoperative hemorrhage. Our tonsillar regrowth rate for what we called intracapsular tonsillectomy has been around 1%. Now, while I think experience is fundamental to the craft of surgery, I love having scientifically rigorous evidence to support my clinical decisions. For example, George Gates' study on children with otitis media with effusion, comparing adenoidectomy with myringotomy alone to myringotomy with tympanostomy tubes, showed that for most kids, the two procedures are equal in protecting against recurrent ear infections. I've tried to use this insight regularly, but with judgment. My experience with adenoidectomy is that complications are rare, and given that tubes are great, but often problematic, the ear findings at surgery will often determine my final decision about inserting tubes. Bottom line, when there's good evidence, I hunger for it, as we all do, and with good reason. Experience is fundamental to the art of medicine, yet it can be insufficient for a deeper understanding of disease. Starting around 1996, we began seeing a new type of catastrophic aerodigestive injury, such as the tracheoesophageal fistula in the picture from aspirated button battery. Given that prior to the 1990s, we had been quite familiar with button battery aspiration without the severe burns we were seeing, clearly this was a new phenomenon. What we realized as the data started to accumulate was that what we were seeing was not a general button battery epidemic, the rate of which had been stable for the preceding decade, but a lithium button battery epidemic with a high incidence of fatal outcomes. Over 95% of the morbidity and mortality was associated with the new type of lithium batteries, and the increasing incidence of injury paralleled symmetrically the increased sale of these new devices. Once the relationship became obvious, the American Bronchoesophagologic Association, the American Academy of Pediatrics, and the American College of Surgeons began to organize a national response of physician education, parental outreach, and industry advocacy, a response that continues today. As I said before, experience is fundamental to the craft of surgery, yet like a single tile in a mosaic, it can be insufficient for a broader understanding of disease. Between 1989 and 2001, I operated on 35 children with congenital cholesteatoma. This disease is different from acquired cholesteatoma in that the kids are born with a keratin pearl in the middle ear that expands over time. Now, I have been keeping an operative journal with drawings of all my surgical cases going back to 1988. I decided to use those drawings as the basis of a review of my experience with congenital cholesteatoma. I oriented all of the cases, whether on the left side or the right side, onto a right ear template, and then arranged them in increasing size. What this exercise demonstrated was the natural history of congenital cholesteatoma as it grows and eventually destroys the ossicular chain and tympanic membrane, progressing to an endpoint where it could no longer be differentiated from an acquired cholesteatoma. This was a clear example of how evidence provides a broader perspective and amplifies experience. The primary reason, the existential reason for embracing evidence-based care is that the five-fold rise in American healthcare expenditures that I have witnessed during my 50-year career in medicine is simply unsustainable, especially as the current generation of baby boomers, my generation, retires. In 2020, the United States spent $3.8 trillion on healthcare, 18% of our gross domestic product. The average European expenditure is 9% of GDP, half of ours. But the real kicker is that for this enormous expenditure of sweat and treasure, we are well behind the other developed nations in major measures of public health, such as infant mortality and life expectancy. Now, there are many reasons for this enormous and excessive expenditure, some cultural, some ethical, some technological, but unfortunately, a lot of the reasons are highly wasteful. For example, there is large geographic variability in the frequency of surgical procedures. The variability can be remarkably granular, as in the fourfold difference in tonsillectomy rates in the counties of Vermont and New Hampshire. All of this suggests an inconsistency in the standard of care by community. This regional inconsistency applies not only to surgery, but to nearly every aspect of American medical care, such as medication use, laboratory tests, imaging, and many more. Consequently, when the standard of care is inconsistent, best practice is elusive. And just as importantly, medical care in the United States accounts for an astonishingly high incidence of error and injury to patients that further adds to the cost. According to the startling report by our Institute of Health in 1991, almost 100,000 people die of medical errors in our hospitals each year at a cost of nearly $30 billion. The sad part is that the numbers of both injury and cost have only gone up in the last 20 years. When considering the relationship between cost of care and the quality of care, after a certain point, an inflection occurs and the quality of care begins to diminish. When our highest reimbursement rates are tied to procedures, the rationale for rendering care is often as thin as air. While we all see the catastrophe coming, it's uncertain if we will be able to prevent it. So we seek a way out of this paradox of higher costs that results in worse outcomes by establishing best practices built on the foundation of evidence-based medicine, which begs the question whether evidence-based medicine is sufficiently powerful a tool for effectively solving this confounding problem. My perspective is that you cannot have best practice without a blend of the best evidence available, balanced with expert opinion based on experience. And I have both very practical and deeply philosophical reasons for holding that point of view. The contemporary volume of medical information seems to be insurmountable, and oddly, knowledge is often elusive. We look for truth within the accepted wisdom of our culture, from our teachers, from current scientific and clinical literature, and when they exist, in clinical practice guidelines. The development of clinical practice guidelines is based on levels of evidence, with randomized controlled trials at the apex with the highest evidentiary value, and expert opinion at the bottom in value. In theory, the development of clinical practice guidelines is a well-defined process of reviewing existing guidelines, identifying randomized controlled trials, taking a topical survey of the literature, reviews by expert groups of available evidence, followed by implementation, authoring, and publishing. But more typically, the development of guidelines is a messier process, where the lack of sufficient numbers of randomized controlled studies requires the added ingredient of expert opinion. All the guidelines I have seen have been written by the expert leaders in the field. And there sure seems to be a lot of clinical practice guidelines being produced to meet the demands of evidence-based medicine. Yet these often turn out to be controversial. Perhaps you remember PSA testing for men, or taking the statins, or performing mammograms. Problem is that evidence is often hard to interpret with a high level of confidence, even by the experts themselves. A good example of this fragile process that strikes close to me is the American Academy of Otolaryngology's Clinical Practice Guidelines on Hoarseness, published in 2009 to near universal disdain. Written by experts in the field, it nevertheless succumbed to groupthink and generalities due to the lack of quality evidence to buttress the recommendations. It is now better remembered for the controversy than its content. Max Planck, famous for his early insight into quantum mechanics, once said that, quote, "Science moves forward one funeral at a time," unquote. The problem with expert opinion is that old stick-in-the-muds like me, who often control the process, find change hard to accommodate to. One interesting and revealing example of a successful launch of a clinical practice guideline was again by the American Academy of Otolaryngology concerning the indications for tonsillectomy published in 2019. Wisely, they left the technique to be used, whether called steel, microdebrider, or electrocautery, to the performing surgeon. The 2019 tonsillectomy guidelines are based on the 1984 Paradise and Bluestone study showing just how recurrent tonsillitis has to be before the children benefit from having their tonsils out. Most of us have been following these recommendations all along, and I have always envisioned this as a matrix of frequency over time, a tonsillectomy index. The Pittsburgh studies, as they came to be known, were the best of their kind, randomized and double-blinded, designed to eliminate bias, reduce variation, and gain statistical power. But even on this important piece of work, if you look behind the curtain, you will see that 3,000 children were entered into the study and less than 200 completed it. And of these, less than half, 91, were actually randomized. I particularly love Charlie Bluestone's quote about his own work, quote, "If you want a problem to disappear, try studying it," unquote. The fact that we had to wait 35 years for guidelines now applicable to 500,000 children annually, based on a sample of 91 randomized children, speaks to the difficulties we face. And just for the fun of it, let's raise the level of complexity. How do any guidelines help the 17-year-old opera singing student who is having chronic throat pain and inflammation from tonsillitis that is interfering with her practice and performance and is unresponsive to medication? Do you decide to do a tonsillectomy on her despite her not meeting a number on our tonsillectomy index? What technique will you use to best preserve her voice? These questions are not answered by any evidence available and best guided by context and judgment. In other words, experience. There are many good examples where evidence informs practice. Preoperative antimicrobial prophylaxis, deep vein thrombosis prophylaxis, vaccination, and many others. Unfortunately, evidence is often inconclusive, inadequate, or simply unavailable. Everyone in the audience can think of many other examples where evidence informs practice, and most would overwhelmingly agree that nothing is more desirable than more evidence for simplifying clinical decision-making. The problem we have as a profession is that too often the evidence is unavailable. Let me give you an example. As we developed the use of plates and screws for managing maxillofacial trauma, we realized the existing sequencing strategies from getting from figure A to figure B were limiting. In the wire fixation days before plates and screws of my residency, we always began with the bottom-up approach, starting with reestablishing the occlusion by wiring the jaws together. In the 1990s, Dr. Joseph Gruss introduced the idea of the outer facial frame, recognizing that facial width varied inversely with facial projection, which was key to a nice reconstruction. And he advocated this approach as the initial step. However, the last repaired segment was the prominent central core of the face, into which were focused the earlier inaccuracies from the other reconstructive sites laterally. This experiential insight evolved into the top-down approach, using the anterior skull base as the foundation for the reconstruction. Given the variability and rarity of these severe injuries, as well as the differential skills of surgeons, I doubt if we ever have sufficient evidence to know which technique is best for which fracture. It's not that we have too much evidence-based medicine, it's that we have too little. Perhaps more importantly, given the dearth of high-value evidence, we need to consider other sources of guidance. None of us waited for a randomized controlled trial before starting to use propranolol for hemangiomas. It was unnecessary. You don't need these to readily observe big differences. What the randomized controlled trial does well is highlight small differences. For example, which is the best dosing, or which of the best beta blockers is the most effective. During the early days of the current COVID epidemic, it became obvious that intubation with ventilation, while life-saving for some, was also responsible for damage to lungs, increasing mortality. The recognition of this was based on anecdotal experience by experts in ICU care. Similarly, the empirical and experimental use of dexamethasone by those same experts resulted in many lives saved. The importance of these insights did not require randomized control studies, since their benefits were readily discernible. As I mentioned earlier, aside from practical concern, I have philosophical problems with a purist, evidence-based approach. Seeking truth is an archetypal search, more noted for the effort than the attainment. I particularly like the aphorism of philosopher André Gide, quote, "Believe those who seek truth, doubt those who find it," unquote. Truth is vitally important, but it always seems an approximation, a bullseye with many circles, all of which are the target. Truth rarely comes with a capital T. In the 19th century, as telescopes and timepieces became more accurate, astronomers found that there was always a distribution of data. Truth was not a singularity, but a circle with woolly edges, often with a large footprint, and the fuzzy boundary represented uncertainty. A key insight of modern philosophy is Kurt Gödel's incompleteness theorem. Gödel showed that any branch of logic, there are always assumptions that couldn't be proven, essentially establishing boundaries on claims of truth. This basic unknowability at the core of philosophy and logic holds true for physics as well. One of the great achievements of 20th century physics was Heisenberg's uncertainty principle, which established the limits of what can be known in the subatomic realm. This fundamental uncertainty at the core of nature has consequences in our complex world, in the randomness that buffets us, whether by hurricanes, heart attacks, earthquakes, epidemics, accidents, and assassinations. All occur with regularity, but capriciously. Randomness is the erratic fulcrum between cause and effect by way of countless variables that define complex systems. Outcomes tend to have a large footprint, requiring statistical description, and statistical interpretation of reality requires acknowledgement of uncertainty. The way I see things, despite our well-established capacity for reason and logical thinking, ultimate truth does not seem to be a privilege of our species. Yet, we have another nature. We are creatures of instinct, exquisitely wired for pattern recognition. Given that a false negative mistake has greater consequence than a false positive one when being stalked by tigers, we have evolved to perceive patterns in the random noise of nature. This wonderful skill is existential to our survival as a species. But as Daniel Kahneman and Amos Tversky elegantly demonstrated, we have two systems of mental machinery to handle the process of information. The phylogenetically ancient one is unconscious and fast, intuition-based, grounded in belief, and prone to error. The more recent evolutionary process of thinking is conscious and slow, reason-based, and grounded in knowledge, and thus more reliable. But as Kahneman and Tversky have shown, instinct and reason are the flip sides of the human coin. Both are necessary to open the gates of perception. Yet perception can be faulty. Our instinct to impose narrative based on random events is at the root of human bias, a human frailty that has been recognized for a long time. Sir Francis Bacon, the intellectual godfather of the scientific revolution in 1620, wrote, quote, "The human understanding, when it has once adopted an opinion, draws all things else to support and agree with it," unquote. In 1966, psychologist Peter Wason termed this confirmation bias and performed the classic four-card experiment to demonstrate our natural tendency to confirm rather than disprove our own ideas. In this experiment, the rule states that if a card has a vowel on one side, it has an even number on the other. Which card do you turn over to prove the rule? Most people get this one wrong because most assume incorrectly that cards with consonants have to have an odd number and that cards with even numbers have to have a vowel. The rule says neither of these things. Actually, the correct answer is A and 7. Turns out there are any number of biases with many subgroupings. We all recognize that our bias can be socially very harmful, as we have been seeing recently in the news. But biases can also limit creativity, innovation, and progress. Yet when you think about it, having a bias really means making choices, and making choices is fundamental to human beings. So how do we move forward? Robert Pirsig, one of my favorite authors, suggests that there are an infinite number of questions to ask about the world around us, countless hypotheses. However, it is our innate sense of quality, our sense of beauty, our intuition, our knowledge, and our experience that help us ask the right questions that lead to insight. This sense of quality, where intuition and reason merge, is what all of us have felt during a challenging case that required skill and knowledge, as well as a measure of courage. Time seems to lose its value, and in the narrowed field of vision, there's an expanded and enhanced consciousness. It is a powerful feeling, and it is the basis of the hard-forged memories that are at the heart of surgical judgment. The English philosopher Michael Oakeshott describes two types of knowledge, technical and practical knowledge. Technical knowledge is readily expressed in rules, can be accessed in books, and is well learned in school. This is the equivalent of evidence. But we as physicians possess and teach practical knowledge, which Oakeshott says exists only in practice. It can only be taught in use, transmitted by imitation, repetition, and experience. This type of knowledge is hard to test, but it is embedded in the response to the unexpected, the strange, or crisis. Each generation of physicians for thousands of years now has passed on the evidence of their experience in the language of their day. Ours has the luxury of powerful new analytic tools, hence the opportunity to identify with greater precision the real patterns of our experience from those imagined. Since the inception of medicine, evidence and experience have been at the core of our craft. Our task is the same as those of our founders: shrink the circle of truth to provide better care for children. We have been bequeathed a rich culture of medicine and surgery, passing that technical and practical knowledge forward to our next generation in a balanced way is our obligation and our privilege. So, in conclusion, I end where I began. Evidence versus experience is a false dichotomy, since one is the wellspring from which the other is drawn. Evidence originates from experience, but then evidence informs experience, modifying it, which then generates new experience, and so on. It is a process as natural as the turning of the seasons. It is profoundly human. It is what all of us are engaged in. Thank you for this opportunity to share my thoughts with you. And it's been a pleasure being part of this department for now 17, 18 years. Thank you so much for allowing me to talk to you today.
Peter, thank you so much for a wide-ranging discussion, very thought-provoking. I have a couple questions of my own, but we encourage participants to write their questions in the chat or the Q&A, and a few have come in already, so I'll just help moderate them for you. The first comes from Sabrina Bram in General Pediatrics, who asks really about your challenge to evidence-based medicine. Do you have a sense of where evidence-based medicine has landed over the past 20 years regarding the reliability of randomized controlled trials since Dr. Ioannidis' seminal paper showing that in time many are proven to be false, many more are proven to be false than true? What are the rational models out there that will help physicians navigate decision-making in the distance between experience and evidence-based medicine?
Truth is hard to come by, isn't it? Even when with our best efforts. The fact is that evidence-based medicine has made great leaps forward and become much more reliable as we become more and more aware, and it becomes more part of our culture. And more of us begin to plan our studies in a way that will eliminate as much bias as possible. So I'm very optimistic that evidence-based medicine is not only here to stay, but will improve our practice. Will it eliminate, or better yet, will it lead us to ultimate truth? Absolutely not. That's not part of the gift of nature to us, but it's something that we should absolutely embrace.
Thank you, Peter. There's also a question here about I think that's, here we go, from Juan Walterspiel. What are the dangers of fixed algorithms and AI as they apply to all of this?
Not being very familiar with AI as on a technical basis, but I can repeat what I've read over the past year, which we've all been exposed to in the various publications that abound. Clearly, garbage in is garbage out, good data in, good data out. If your data in is insufficient to cover all the diverse elements of our population, then the data out is ultimately going to not reflect that diversity. And I think that that's the greatest problem in terms of the medical field. Now, there's all sorts of other interesting social and political consequences of AI. For example, there's wonderful benefit, for example, of being able to identify the perpetrators of a crime, such as the Boston bombings, by having available photographs that identify faces. On the other hand, look at China and the concern over the control, Big Brother type control over the society using the same technology. So AI is not good or bad. It's how we as a culture use it. And I can assure you that you're going to see good examples and bad examples because of human nature.
Right. Back from Boston and China to surgery. Good question here from Paul Grimm. Could you talk about incremental surgical innovation and whether or what level of innovation is patient consent needed? For example, would you ask for patient consent the first time you use a new device to do adenoidectomies that had been designed and used for another indication?
You know, times have changed, and I got away with stuff that I couldn't get away with today. But I can tell you the first time I did the powered adenoidectomy was on the daughter of the chief of pediatric anesthesia at Albany Med. And I said, hey, Lauren, I have this new idea about using this device for doing the adenoid on your baby. You mind if, would it be okay if I did? And she said, sure, go ahead. So we did. And it was, again, there was no IRB oversight for that. Today it's different. You couldn't do that, and probably wise, but it does impede to some extent the creative process because it's hard to gain experience when you've got to know ahead of time what you're trying to gain experience with. But at the same time, it certainly is more protective of patients. So as I say, I'm from a different era. I grew up at a different time and matured into a surgeon at a different time when the rules were different. So perhaps I was lucky, and perhaps some of my patients were less so.
Right. The next question, I'm going to kind of take the privilege of merging one from Jeff and Dan. I presume that's Dan Bernstein. They're really talking about what you recommend moving forward, given this conflict between, evidence and experience. So Jeff says, how do you explain when new EBM is published, but physicians say, yes, I saw that article, but I'm still going to do things the way I have been. And Dan asks, often the recommendations wind up being based on minimal evidence or consensus of experts, as you say. How do you suggest that we change the way our profession balances these divergent types of recommendations? What's your prescription, doctor?
There is no solution to that, frankly, but it's like diabetes. You can't cure it, but you can manage it. And I think that that's the best answer I have. I'll go back to Persig when he talks about sense of quality. And what he means by that is where the subjective and objective feelings come together. When your sentiment tells you that you're doing the right thing, it's usually you are. If you don't mind what you're doing being published on the front page of the New York Times or having to tell your mother about it, you're probably doing the right thing. And ultimately, there is no one answer to that question. Each time you have to make a decision and make the best decision possible.
Peter, I'm going to add a question of my own as these other questions come in. So it looks like you really like the philosophy of science, as do some of our participants. And, I'm going to take you referenced Heisenberg and Bacon. I'm going to challenge you on Immanuel Kant, who talked about the technologic imperative. And you didn't really speak about this as a surgeon. We experience this more in medicine often as the perverse incentives of the US healthcare system, where procedures are incentivized, and often cognitive medicine is less so. And I'm wondering how you think that plays into the unwarranted variability that Wenberg and others originally pointed, particularly in high volume procedures like the TNAs and the PE tubes that you pointed out. Shouldn't we really be doing fewer of them in aggregate and reducing that variability as a way to combat that technologic imperative?
That's a great question. I must tell you that I've tried to read Kant and I can't get past the first 10 pages. Find his work very obscure and difficult. But that said, I think the fundamental problem really is the capitalist market-based medical system that we have. And things are not going to change until that changes, until that system is left behind for universal health care with reimbursement that makes more sense You know, I think it was Mencken who said that it's hard to convince a man of your point of view when his livelihood depends on not understanding that point of view. I agree with that. You know, most of us, when we're incentivized to earn as much money as we can based on our skills in the operating room or in the radiology suite, um, are going to have self-interest, whether we acknowledge it or not, uh, sitting on our shoulders. And until the system changes where that incentive is removed, you're not going to change the number of procedures being done unnecessarily or being done for marginal reasons.
Thank you for that. Peter, I also just want to make sure that you see, and we'll save for you, the thanks and appreciation of your wisdom and your experience for this from many people, but also for your art and the beautiful presentation that you provided. I'm curious also about how art has influenced your view of this. You talked about, you know, your experience in the Huntsville prison, your experience with the starplasty, and how you know, really it brought you back to, you know, childhood. You know, we're all pediatricians here. What do you think is the prescription for the other side from evidence, experience, namely imagination? What do we need to do to liberate imagination to solve these complex problems in medicine?
I think the answer to that is listen to everybody. You know, I have a particular gift of being able to visualize things ahead of time. For example, I'd go into the operating room on a big case. I knew I could see every step I was going to take along the way. I don't know if everybody has that kind of vision. My wife, for example, she says, when I close my eyes, I see dark. So again, I have a particular gift that I've been blessed with. That impetus is inherent in many of us, and it just needs to be nurtured. Needs to be nurtured from an early age. And you know, when a kid shows a propensity for being able to draw or being able to write, that should be encouraged and helped in as much as possible, because the fruits of that later on in life will manifest themselves in unpredictable and often very beautiful ways. So I don't have much more to say about that. It's just part of being human, having an imagination and relying on your past experiences to give you a vision of the future. That's unique to our species, and to envision our future. Somebody once said we should be not named Homo sapien, but Homo prospectus, being able to prospectively see ahead of what might or might not be. And we should all kind of foster that sense in each of us. And I think that will open up the gates of perception, as William Blake says.
Wow, very inspirational, Peter. I'm going to give you the last note on a question from an anonymous respondent that picks up on this. That our teachers and our trainees have outstanding ideas, yet competition and hierarchy in academia can sometimes suppress these great ideas, this imagination and prospectus that you were just talking about. How can we enable the next generation without threatening them to unleash those ideas?
See, I don't see it that way at all. I see that the current, I mean, for example, I'd never get into medical school today, or get the residency I got, because my grades were just not that good. The current generation of young men and women coming through the system are very bright, very motivated, and will do just fine in the academia. What we need to do is get more of them into the academia. blaming hierarchy and blaming external forces for your lack of progress, to me, is an excuse, and nothing more than that. Yes, there are biases against certain people. There's impediments to certain groups, certain genders. But if you persevere, you overcome. It's as simple as that. It's putting your feelings and your thoughts into action rather than complaining about your inability to do so. I think that makes the difference. And again, if you're finding pushback, then push forward harder.
Well, Peter Koltai, thank you so much for inspiring and informative Grand Rounds. And we're at the top of the time. And thank you, everybody, for participating and sharing your comments and your words of appreciation for Peter.
Thank you for the opportunity to be here today. I think this will probably be my last presentation at Stanford, and it was a delightful one for me. Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.